we can't go into the management of all these AEs, but one of the things that I've been frustrated with in the management of patients referred to me is that there seems to be a tendency to bail on a drug because of adverse events a lot quicker than we should. And they come to me saying that they're intolerant of everything. And now what do you do?
Yeah, I agree. I think we need to differentiate between the patient's intolerance to a drug and the doctor's intolerance to the side effects of the patient, because the easiest thing is to change.
Yeah.
And sure, I mean, we have many TKIs and that's good, but the problem is you end up going through all of them if you practice like that, because all the drugs have some side effects, but most of these adverse events you can manage through them. And you never know when the change could expose the patient to an adverse event that's even worse. Let's say that you're worried about the diarrhea and you change them to something that gives them a heart attack, for example, or you change them because of a rash and you end up getting a liver toxicity, which is worse. So manage the adverse events. Most of them can be managed. When it definitely doesn't work, then sure, a change in therapy is indicated.
So I think you've done a good job of already discussing some of the toxicities we see with Ponatinib in terms of hypertension, I agree there, and also arterial occlusive events. What tips can you give us about how to manage patients that you're treating with Ponatinib? Do you change the doses? Do you prescribe aspirin, statins? What do you do?
Well, one of the problems we have with the arterial occlusive events is we don't really understand the mechanism. My feeling is that this is an able effect, because we see it across all the TKIs. The one that has the least is imatinib, but it's the least potent against able, so it still could be compatible with that theory, but it's just a hypothesis at the moment. And that makes a difference, because we don't really know, and we haven't prospectively studied what to do for these patients. But I mentioned already, managing the comorbidities, that's important. I think that it is likely that using statins, or at least it's possible that using statins can help some of these patients. Using aspirin, I use it. I don't know if it's going to help, and there's some reports that suggest that Ponatinib already has a mild but an anti-platelet effect, anti-aggregation effect. So I don't know how much they're going to help, but unless the patient has a risk for bleeding with aspirin, I think it's a low-risk intervention that may help. And then the dose is an important component. When we started, we did some modeling, and we estimated that by reducing the dose by 15 milligrams, you would reduce the risk of these events by 40%. That was modeling based on the doses that the patients were taking at the time of the event and all of that with PACE. So what's happening now is that there's an ongoing study called the OPTIC trial, where we're prospectively, patients who start on Ponatinib, randomizing them to receive 15, 30, or 45 milligrams. Now, the results are not out. We'll see them, and they'll inform us. I think it's become fairly common, and I do that patients are, in the chronic phase in particular, I tend to use 30 milligrams to start. In the patient that's not meeting the goals, I may increase to 45, but I start with 30. Now, in the more advanced stages, a blast phase patient, we talk about the Philadelphia positive ALL, I'd rather start with 45. Now, once I get a remission, I may cut back, but those patients need a more rapid response, so starting with 45 makes sense. So the dose, I think, does play an important role.
Yeah, I've actually had the exact same practice in those two different situations of where to start and what to do with dose reductions. Well, that's been a great discussion on the management of the toxicities of Ponatinib.